Hello, my name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center, and I want to thank you for joining us today for our UMTRC webinar series. Today, we have a guest speaker, Micah Dean, and he holds an MBA and is part of Cincinnati Children's Hospital since 2013. So Micah today is going to be talking to us about remote patient monitoring and his role in the business development group. Before I hand things over to Micah, we are recording today's session. We will post it on our YouTube page and our archive webinars on our umtrc.org website. We ask you to go ahead and ask questions throughout using the Q&A function at the bottom of your screen. And the chat function should only be used for technical issues. So without further ado, Micah, we'll hand things over to you.
Thanks. Thank you for having me today. So today I'm just going to talk a little bit about what Cincinnati Children's has done over the last 4 or 5 years to build an RPM program and some of the goals associated with that, and then the outcomes that we have observed during that time. So with that, I'll get right into it. So a little bit of background just to get everyone level set. I know there are a few different varieties of RPM out there. I think it's becoming more standardized as it evolves. But what we are doing currently is providing patients and their families, in the case of younger patients, with an app to connect back to the medical center between their on-site visits so that we can monitor their health and address any concerns before they escalate to a serious issue. So the way we do that, on the bottom right corner of the screen here, you see we have co-developed an app with our vendor that can be added to any iOS or Android device. And then that information flows back to us through a cloud server in near real time. And we'll get a little more into that, where that data goes once it reaches us, in a couple of slides. So why do remote monitoring? A lot of people talk about the convenience factor of it, and sometimes it's a little bit nebulous to understand what the actual benefits are. So when we're developing new programs, we try to consider 4 different buckets of goals that we would like to achieve. So the first one is to improve the experience both for the patients and their families and the providers. Anytime you can make something more convenient for a family, I think they're going to appreciate that, even if the outcome is equivalent or unchanged from what may have happened in an in-person visit. If you can save them a 30-minute commute or a bus ride or a missed day of school, whatever it may be, that goes a long way. And we've seen that in our survey results and the comments that we get back from patients. Providers also appreciate the opportunity to do RPM and free up their schedule when they're working near capacity in their clinics. It's important to make sure that the patients who really need to get in and be seen in person are able to do that in a timely manner. So RPM is a great way to sort of stratify who should be coming into the medical center and who can wait a little bit longer. So that's had positive impacts on metrics such as the third next available appointment in many of our specialty divisions. The second bucket we look at is value, which we measure by reductions in utilization in its various forms. So inpatient visits, outpatient clinic visits, ED, urgent care, all those different areas. And we pull baseline data for each of the patient conditions for usually 24 months prior to implementing an RPM program. And we compare that cohort of patients' outcomes to the patients who we enroll. And we try to make sure that we get sort of a critical mass enrolled so we can achieve statistical significance when possible on those outcomes. And we'll talk more about that in a few slides. And then also reducing expense to the family is important to us, because we all know that in some cases, if a patient is very ill, one particular bout may result in multiple visits to a specialist. And every time, at a minimum, they're paying a copay, and they're paying the travel expense and all those other associated costs. So any way we can reduce that for the patient, we want to do that. And then the final bucket, which is maybe the most obvious, is the clinical outcomes. Anytime we can, we want to use this tool to have better health outcomes for our patients, whether that means achieving a desired state sooner, or in some cases, being able to monitor things more closely and totally avoid any kind of infections or downward spiral that may occur, say, after a transplant surgery, something like that. Just having a constant finger on the patient's pulse. That's kind of a bad pun, but knowing how they're doing is very helpful. So here, this is a lot of words on a slide, but I'm going to summarize it the best I can. This is basically just talking about the ways we use the tools available to us through remote monitoring to achieve the goals on that previous slide. So really, the meat of these programs is what we call care pathways, which are basically questionnaires that have branching logic built into them. And they're developed in partnership between our specialty care teams and the RPM nurses. And the goal of these is to gather all of the information that is necessary to help the patient while not burdening them with too much of a time commitment each day. Because what we've seen, and also what you can find in a lot of the literature, is that if patients are being required to do too much each day or each week, then that results in burnout, and their compliance with completing the questionnaires and providing the biometrics begins to dip after 10 days to 2 weeks. And that's definitely something we want to avoid, because if we're not receiving the information from the patient, then the program is no longer valuable to them or to us. So the frequency of the pathways varies by the condition that the patient is being treated for. The average is 3 to 4 times a week, but we have the whole spectrum. We have some patients who respond multiple times a day, and we have some patients who only respond once a week. So it really is on a per patient basis what their needs are for us to best treat their condition and meet their needs. As the information flows back to the hospital, it's triaged by our team of RPM nurses Monday through Friday from 7A to 7P in accordance with a predefined response plan that's developed at the same time as the pathway. And what the response plan does is clearly define who should respond to each type of alert. So we stratify medium alerts and high alerts based on what it is, what the patient's condition is, sort of what their baseline is. One example, recently we've had a new group of patients who were consistently triggering alerts for having low temperatures. And they were coming in with readings in the 95, even high of 94-degree range, which is abnormally low for most people, but these patients are very ill, and they are sort of hypothermic by nature. And so we were able to adjust that and set what their normal is for that patient, and so that we're not on our end having alert fatigue, because that's another danger in this. If patients are being asked to do too much, they become fatigued. But if our nurses are seeing too many alerts that they know are not valuable, then they may miss something that is very important. So we want to make sure we only trigger alerts when it's necessary and valuable. The next thing we do is collect biometrics and vitals through Bluetooth connected devices. We have all the basic things you would think of: scales, BP monitors, thermometers, and then we have some things that are a little more uncommon in the home, like pulse oximeters. We're evaluating some other things. We have infant scales, cradle style scales for the tiny babies who we discharge from our NICU on the program. And whenever possible, we try to have that information flow back to us without any manual entry requirement from the family for a couple of reasons. One, it reduces data entry error, and two, it ensures data accuracy, which is more of a concern sometimes with our like teenager and young adult patients who sometimes will respond in a certain way just to maybe not trigger any alerts because they don't want the hassle of coming into the hospital. So that's something that we try to avoid whenever possible. Our next capability is video visits. So we do have a little bit of a traditional telehealth flavor in the RPM program as well. So anytime a patient or family request a video visit, we can set that up either with one of our RPM nursing team members, or we can help to coordinate and schedule one with their specialist provider. And then even if the patient's not feeling unwell, we try to check in at least once a month by video with the families so that they feel that continued human connection and they don't feel like they're just working with a computer or a device on their health or their child's health. So we like to have sort of a continuity where they see the same people if they're on site for a visit or if they are participating in an RPM program. And then two more things here. One is HIPAA compliant messaging, which is a relatively new feature for us. And it works very similar to the stock texting app that you would have on any smartphone, but it's fully HIPAA compliant. So we can share PHI, can share imagery of say a dialysis catheter site, anything like that. And there's no threat of that being viewed by somebody who's not part of the care team. That's been especially popular with our young families. A lot of times we'll try to reach them multiple times by phone, and either because of a work situation or a busy lifestyle, they're unable to answer the phone and get back to us quickly, but they'll get right back to us by text. And that is the preferred method of a lot of our families that we see on surveys. They like to be contacted by text. So that's also helped with satisfaction. We see that on our surveys. And then the final aspect is the education library. So we're able to upload any form of written or recorded video education for our patients. And that exists in a variety of forms. Much of that is created in-house by our care teams. So again, they get to see those familiar faces, and it's kind of cool for the kids who develop close relationships with their nurses to see them there on their device, talking them through things. And then some of it is stock education that's made by, say, a medical device vendor. If a patient's on dialysis, we can upload info on their dialysis machine. So then if we get a call or text in off hours saying, I'm having issues cycling the machine or whatever it may be, then we can tell them, refer to page 42 on this file, and they can go straight to the library and find it. So that's been a really valuable resource as well. A little more background on our specific programs. So we currently have 7 active patient populations. So we have the NICU follow-up clinic, which is for babies who are discharged either on oxygen support or with an NG or G tube for feeding support and trying to gain that weight to get them up to what would be a healthy birth weight. Then we have peritoneal dialysis, oncology for patients who are undergoing chemotherapy, adult congenital heart disease, renal transplant, liver transplant, and hemophilia. We also have 5 new populations in various stages of development. We're working on pain clinic with our anesthesia division, failure to thrive for those younger children who are unwell and having a variety of struggles. GI for patients who are on home TPN infusions, cardiology for patients with a VAD device, and then asthma. The DTT is for difficult to treat. So we have a large asthmatic population here in Cincinnati, and we have them stratified into various groups. So that difficult to treat is sort of our 10 to 15% of our patients who are the most critically ill with asthma, need the most attention. We've enrolled 520 patients since launch, and we currently sit at around 180 active patients per month. That fluctuates from time to time, but for the last several months, we've been between 170 and 195. And then our compliance is around 80%. And we define compliance as the patient completing all the questionnaires and reporting the vital signs on the requested time interval. And they have to do everything to get credit for it. So if they complete the questionnaire but don't provide us with, say, a weight, then they get 0 credit for that day. So it's kind of a tough grading system, but it's also the most conservative way of monitoring our patients' participation and compliance in the program, because we know that the more compliant they are, the more value they will realize from it, and also the more value we at the hospital will realize. This is just a quick visual look at the growth of our program in terms of active patients per month. You can see it's been a steady increase ever since November 2017. And the numbers were very low then, and the program actually dates back a little earlier. There was a time when we would only have 5 patients a month across a variety of pilot programs. And that was really for the purpose of testing equipment, testing out various vendor platforms, trying to come up with communication strategies of how our Center for Telehealth could work with various specialty divisions. And once we got all those kinks ironed out, we began to roll it out on a broader scale. And as I mentioned, now we're just under 200 patients a month, and that's going to grow significantly in the near future as we launch some of those new programs in development. The staffing model is something that we also worked pretty hard to tune in during that pilot phase. And we looked around in the literature, talking to other hospitals who had RPM programs live at the time. And even just a few years ago when we were doing this, there weren't nearly as many as there are now. So it was kind of difficult to figure out what the right way of doing this was. And in full candor, we did it the wrong way the first time. And what we tried initially was having nurses and providers within the specialty who were treating the patient also staffing the remote monitoring portal. And what we found was that between their normal clinic schedule and seeing patients and charting, they just didn't have adequate time available to be in the portal monitoring it on a regular enough basis to provide value. And what I mean by that is a patient may have triggered an alert today for a high blood pressure, and it may have been 24, 48 hours before anybody got in the portal and saw that. So that's not a safe scenario for anybody. And we always try to educate our patients that this isn't meant to be an emergency system. And if they know something is wrong, they need to go down their normal avenues of calling their care team or calling 911 if it's an emergency. But at the same time, we understand from the patient's point of view that if they're providing us info, there's the assumption and that feeling of a safety net that somebody's seeing it. So when we realized that things weren't being addressed in a timely manner, we knew we needed to take a different approach. So what we did was partner with our float pool that we call the SRU, or the Strategic Resource Unit, to recruit 4 nurses to fill 2 FTEs. And the idea was that they would rotate in 3-week blocks with a little bit of staggering in there, so that they would maintain their bedside clinical skills and also stay up to date with all of their nursing education and things like that, but then also be able to help us out in telehealth by monitoring the portal in real time. And what we set up was a schedule of 7 a.m. to 7 p.m., Monday through Friday, with 2 nurses a day. So we have a nurse who comes in at 7 and stays until 2 or 3 o'clock. And then we have a second nurse who comes in between like 11 and noon and stays till 7 p.m. That way we're able to cover the full 12 hours, sort of daytime hours for our patients. And then we also have some overlap in there so that if we have any program development meetings, team meetings, anything like that, one person can participate while the other one is still in the portal and addressing things, responding to text messages, all that kind of stuff, and as close to real time as we can. And something new that we have actually starting today that we're really happy about is one nurse who's going to be with us full time in telehealth. And she was one of the original team members of 4 who's been with us for about 3 years next month. And so she'll be transitioning over, and a new nurse will be backfilling her. But she'll be working full time with me to bring clinical expertise to the early stages of program development. Because now what happens is when I go to a meeting, we'll have providers, nursing leadership there, and then I'm not able to answer a lot of the more clinically focused questions on RPM. I know the platform well, and I know the technology's capabilities, but now by having this nurse to partner with me, she will be able to really make a lot of suggestions based on her firsthand experience of what might work well and what may need to be done differently in order to achieve the greatest value. So we're really excited about that change. And also that takes us up to 3 FTEs instead of 2. So we'll be able to monitor a higher volume of patients. And the way we shoot for that is through trial and error, and also putting together some of what we were able to find in the literature. Our nurses can safely monitor about 80 to 100 patients each, or per FTE, I should say, at a given time. So right now, like I said, we're at that 180-ish range with 2 nurses prior to today. So we were basically working at capacity or slightly above sometimes. So with the addition of this new nurse, it's going to help with our expansion. And then 1 program manager, that's me. And then at a higher level, our leadership comes from our senior director, Jen Rushman, who is just an awesome champion for RPM and really great leader in our hospital. And then our medical director, who is Dr. Ken Techmeyer, who started with us at the beginning of this year. And he's also been a really great partner helping us to communicate with physicians and sort of address from that angle with his expertise of helping us to identify new populations of patients who could benefit. So on the bottom right corner of this screen, it gives just a quick snapshot of our demo portal. And this is what the dashboard looks like. We're able to see our patients in a list, and it's coded in a stoplight format. So green is good, yellow means there's a medium alert, red means there's a high alert. So you can see some of the red areas lit up here, and that's just sort of at a glance what our nurses can see when they log in, so they can triage and know who needs attention the soonest. Some of the key partnerships that we've developed, I've touched on a couple of times. The specialty division is critical. Having buy-in and an identified nursing champion and physician champion goes a long way in ensuring the success of a program. And early on with our pilots, sometimes we may have an administrator who came to us with the idea, or we may have one nurse who was not in a position of leadership who was excited about it. And that's an uphill battle when you do that, if you don't gain buy-in prior to launching, because then what you have is a discrepancy in which patients are receiving orders to be part of the program, and then also the consistency in which they're treated through RPM. So a more concrete example of that is when we began with our dialysis group, we had one nurse who was very involved. And anytime we had an alert for one of her patients, we would let her know, and she would immediately address it. Some other nurses who weren't as closely involved with RPM, when we let them know, they didn't want us to participate as much in managing the situation. They wanted to sort of own it, and they felt, rightly so, a very close relationship with their patients. But since they were unfamiliar with our nursing team and exactly what we were doing, how we were doing it, then they had a lower comfort level with the system in general. So what that taught us is that we do a lot of education leading up to the launch of a new program. We make sure that everybody who could potentially be involved is aware of what it is, why it's being done, who we plan to enroll, what we're going to do with their information. And just having that clarity is huge in terms of down the road success. And then the second thing here is the vendor. And it seems obvious that you would have a relationship and a partnership with your vendor, but we've worked with a few different ones, and one for our platform, but then several for devices. And I think it's important that if you are launching a new RPM program, that you have a very open dialogue to make sure the vendor understands what your end goals are in terms of like an integration with your electronic health record, if that's something you plan to do, which devices you plan on using, whether or not those Bluetooth devices are compatible with the platform, because you take it for granted sometimes, every patient's got an iPhone or an Android who's being enrolled. So you think, yes, their Bluetooth device will work, but that doesn't automatically mean it's going to work with the RPM platform. So there's a lot of those types of considerations that are easier, more easily addressed up front rather than trying to do rework after you go live. So in terms of developing new programs, during the original pilot stage, it took us quite a while to build and launch a new program, and it could be up to 6 months. And like I said, a lot of that was because the nurses and physicians had their regular clinical schedule that they had to maintain in addition to doing this. So they just didn't have any time blocked out to work on this. And we didn't have sort of a well-defined working team or a clinical person on the telehealth side who could spearhead it. So over time, being able to have our dedicated core group of RPM nurses, and then identifying a nurse and an MD champion for each of our new programs, we've been able to get that launch time down to about 4 to 8 weeks. And really much of that flux is on the vendor side for the coding and development that they have to do. But in terms of pulling baseline data, coming up with the care pathway questions, the education, response plan, we have templates for all that stuff now. We can knock it out in 2 to 3 weeks. So we've become much more streamlined and are able to really go live much more quickly than we could in the early days. So we've talked a lot about RPM outcomes. So on this slide, I just have some examples of what we've observed through for a few of our different patient populations. So for peritoneal dialysis, we were able to reduce the number of inpatient days per patient per year from 8.4 to 5.6, just within the first 12 months of launching RPM. And subsequent analysis has shown that number has actually gone down even more. And again, in transparency, the second year it ticked back up a little. So we went from like 8.4 to 5.6 to 6 something, but now we're back down even under 5.6. So that's been a very successful group for us. With our ACHD high risk population, we enrolled 24 patients, and they were averaging 3 inpatient days per patient per month, which had an associated cost of about 3.1 million. And we've been able to reduce that by about 20%, which equates to $632,000 in annual cost savings. So that's been a pretty great success story there on the financial side. And then of course, there's also the clinical aspects of this, but I'm just adding in a few different examples here of various aspects of what we've been able to observe. And then finally on the NICU, that's our largest program in terms of patient volume. And it's tracking to also be our largest in terms of impact for utilization and outcomes. We recently did a research poster on this in partnership with Dr. Tanya Cahill, who is our physician lead for the program. And what it showed was that for the first 85 patients enrolled, which accounted for about the first 6 months of the program being live, readmissions within 90 days of discharge were reduced by just over 50%, which was huge. And that, according to our analysis, was statistically significant. Then the initial length of stay in the NICU was shown to be decreased by an average of 10 days per patient. But because of our small sample size, that outcome was not statistically significant, but we're approaching that. We're planning to do another analysis because we've enrolled about 350 more babies since the time we sort of cut off the data to do this analysis. So, excuse me, what we're hoping and sort of expecting to see is a continuation of those trends with demonstrated statistical significance on both aspects. And then in terms of plans for the future, one of my early slides shows that we have 5 new programs in development. We fully intend to launch all 5 of those and then go out and identify more. And really the only limiting factor for us right now is nursing capacity. And we have great support from hospital leadership, and they've shown that as long as we can continue to demonstrate successful outcomes, that they'll support us with the resources we need, both in terms of nursing and technologies and things like that to expand. On the payment front, much of our patient population is insured through Ohio Medicaid. And until this month, Ohio Medicaid did not offer reimbursement for remote patient monitoring. But in a very fortunate turn of events, that was added this month. So we are beginning exploration of that, and we're going to work that into our program so that in addition to the cost savings, we're realizing we can have some direct revenue to put towards the program, which can also help resource some of the growth that we want to achieve. We're also continuing to investigate new technologies and platforms, not necessarily because we're unhappy with our vendor, but we take the approach across all of our Center for Telehealth that it's always a good thing to know what's coming down the road, what's on the roadmaps for various vendors. Even if it's 2 or 3 years down the road, we want to know what it is and consider how that may be able to help us and help our patients. And then the final thing, which maybe I should have put first because it's really top of mind right now, is a closer integration with our health record. And we're on Epic here at Cincinnati Children's. Right now, all of the information does flow back through our vendor's web portal, but any medical management our nurses do and anything that we observe through that is documented within Epic. So they're kind of working in 2 systems and it's very manual. So ideally, we would like to have some of that information flow in directly, and then in the future, if we were able to launch some of our program through Epic's upcoming RPM module, that's something we would be interested in as well. And that's all I had for the slides. I'm happy to take any questions now that are out there.
Thank you so much, Micah, for being with us today. You guys have done some great things. That's awesome that the program has been around so long and that you've seen so much buy-in from the higher ups at your organization.
Thank you. Yeah, they have been very supportive. I can't say enough. Again, Jen Rushman, our senior director, has been a great champion for us. And so a lot of that support from higher up has been because of her leadership and her messaging to them. So I appreciate that.
Do we have any questions from the audience? Now is the time. And while you guys were waiting on questions to come in, while you guys are doing that, I will, we do have a survey. Our program is federally funded, so our funders often ask us for feedback on our programs, and I want to give you guys a chance to provide feedback, and we will provide that to you, Micah, as well regarding the presentation. So I'm going to copy this and put this in the chat here. And I did want to give kudos to the Michigan Medicaid. They've made great strides in the last 18 months or so around reimbursement for telehealth. So I'm very pleased that you're taking advantage of that and being able to get reimbursed for that. One thing I did want to ask, Micah, I can't remember if it was in your presentation or not. Are you guys part of an ACO, an accountable care organization?
So we were previously, about a few years ago, I don't remember, and we're re-entering one now, and we're in the process of that, but I have not been a part of that work to this point.
Yeah, we've seen such a huge uptick in interest for remote patient monitoring programs, especially with COVID and so many patients trying to stay home and receive care from home. So it's great that the reimbursement's keeping up with it.
Yeah, and obviously it's a great option for ACOs. Once you're going at risk with those patients, it's a great way to improve health, deliver health without having to bring them in.
Yeah. All right, so if you look in the chat, there's the link to the survey. If you would take time to fill that out before you exit today's webinar. And then I am not seeing any questions. If there are questions after today, feel free to get a hold of one of us. You can email us at info@umtrc.org. And if we need Micah's assistance answering that question, then would it be okay to reach out to you?
Absolutely.
Okay. All right. Well, thank you so much, Micah, for being with us and sharing your time with us today.
Thanks for having me.
All right, everyone, have a great day.